Is that all right? Are you ready?
Yeah, I'm ready.
No worries. All right, I'll have it on there. You can stay unmuted during this process. No worries at all. Can you see that at all on your end?
This is a patient that I had at Milan Pushkar Health. Yes, yes.
Yes.
Yep.
Are you able to? Okay. Okay. And so this is a 49-year-old male. The first time I saw him last year was in August, and he came to me. He had recently been diagnosed with Hep C, and he thinks that he got it from sexual contact with a girlfriend at the time. He was in kind of a bad state mentally as well as physically, and he was still using IV drugs then. I spoke with him the other day, and he at this point would not have used IV drugs in more than 3 months. So he has met that requirement. Now, at the time I saw him in June, he was still using, his last use had been 2 months prior. So he's met that criterion. The group look at this as a emergency sort of need, but it's been kind of prescription written. So I'll be thankful for any input here. But sorry, I got ahead of myself on this guy. So he has a fairly high viral load. But he didn't have any CBA tenderness. So I wasn't sure what was going on with that. And then when I got the lab work, then finally, I mean, it took him a while to get that lab work done and to come in and have a urinalysis. In fact, I had ordered that last year when I saw him, and he never got it done. So this was the first time that I had even seen his urinalysis, but it did have urobilinogen in it and blood. And so that just indicates some liver dysfunction there. And then when his initial viral load was done, it was over 5 million. His most recent was about half of that. And so at this point, he is denying any IV drug use now. He denied then using alcohol, but he denied it. When I quizzed him further, it was regular alcohol use, because once I talked to him a little bit more, he said, well, yeah, he had some drinks, and I gathered quite a few the day before because it was his birthday. And so I believe, really has cut all of that out. And he does use marijuana, but he tells me he's cutting down, and he tells me he's down to about 1 cigarette per day. You know, that's probably a give or take, and more likely give, but he tells me he is cutting way down. And I think he really is motivated because his sister had a lot to do with him even getting to this point. And this sister, who was so instrumental in pushing him along, getting him to get into treatment for various issues, passed away about 6 weeks ago. She actually committed suicide. And so when I spoke with him, he was just determined to do this for for her to get treated, and for his daughter. He just adores his daughter. She is an older teen, young adult, and so he's very determined to get cleaned up for them. And so I give him some benefit of the doubt on all of these things. I think he's genuine in his desire to stop all of these things, and he is being treated for, you know, usual stuff for a man his age, you know, cholesterol and blood pressure and COPD, because he was such a heavy smoker at one time. And then he takes buspirone for his depression. And so I think, let's see, there.
You're cutting in and out a little bit, Susan. We might have lost her. Susan, if you can hear me, I would probably turn off the camera. It might help. There you go. Can you hear us?
Are you still able to hear me?
Now we can, yeah, you cut in and out a little bit. Yeah, I would just have the camera off. It might help that connectivity issue, but I can hear you better now.
I'm so sorry.
Okay. You're in and out a lot. You might,
yes,
it's okay with
the next page.
Can you see it? I mean, I might just scroll the page, and I know everyone can see it at this point, if that's okay, because you are having difficulties. I hope you can hear us. But does that sound okay if I just scroll down the page and have a discussion on that?
Yes, go ahead.
Okay, no worries. I apologize. No, it's okay. So yeah, I will scroll down if everyone can see that. And if they want me to keep it on the screen, that's completely fine as well. We'll just, I'm at the body mass index right now.
Okay.
Basic laboratory results.
And I have an APRI score there and a child Turcotte-Pugh score, and so I thought that would help. I've ordered the FibroSure and elastography, but when I checked this morning, he didn't have those completed yet.
Perfect. Thank you for that update. Yeah, I can see the APRI and then the child. Can everybody see that okay? Am I going too fast or anything? I apologize. Thanks for your understanding and patience. And then the question, you know, should anything else be done for blood? Oh, I can't say that word. I apologize. Don't want to butcher it. I will keep the additional information up or scroll up if you guys want me to. But, you know, didn't know if that changed anything or if anybody else had any ideas from what our post-session recommendations were already submitted. Did you have any more questions after seeing those, Susan?
No, no.
Hey,
All right, I'll
hey,
just,
Sue. This is Kaylee. Do you have an INR on him by chance? I know you're in your course, so I don't know if you have access to anything other than the sheet. But I didn't see. I was trying to look. Do you happen to have an INR?
I do not, and because at HealthRight they're so difficult to get. We have to send them over to WVU to get those done. And shame on me, when I ordered his FiberSure, I never thought to put that on there and include it.
That's okay. That's okay. I was just trying to look over his case because I know, yeah, you'd originally sent it as an on-demand, but I thought he would be a good discussion case for us too. But so if anybody else wants to talk first, go for it. Otherwise, I'll kind of go through my thought process. But I want to give anyone else the opportunity to first.
I'm just going to jump in for a second. This is Sue, and bring everybody's attention. I don't know if you noticed it as we went through, but he's a genotype 3, which is kind of unusual.
Yeah, so the things that kind of concern me about his case, I mean, you know, with his liver enzymes are really high. So I mean, his ALT is almost 400, which could be just from Hep C, but and you know, he's not he's 49, but he has several factors that could also put him at risk for fatty liver disease, in addition to the hepatitis. And it does seem like he's got at least pretty advanced fibrosis just on the panels that have been done thus far. If not, you know, even potential for cirrhosis. So it's super great that he's not, you know, drinking or really I would tell him he's got to stop completely though, because he could really kill his liver quickly that way. But it looks like he's, you know, really cutting out the drugs and he's motivated and he's got his tobacco and marijuana use fairly optimized. So, but his high blood pressure and cholesterol, his history of alcoholism, I mean, all those are predisposing factors to fatty liver and liver disease in addition to the Hep C. So that may be also why he's got this inflammation. And you know, with his APRI being that high, 2.7, so remember that the cutoff where we really get worried is 1, and then anything over 2 is very specific for cirrhosis. So even without a fiber test, I definitely get imaging on him, but I guarantee your fiber test is going to be elevated, probably F4, especially with his degree of transaminitis. Plus he's got this genotype 3. You know, all those are kind of factors that put him for higher risk of liver disease progression. Remember that genotype 3 is the one that's more aggressive. And so you can actually develop pretty significant liver disease in, you know, 5 years as opposed to 20 years with the other genotype. So definitely would err on the side of getting him treated sooner than later. The reason I was asking specifically about the INR was, and I know you said you had his child's Pew down and it was 2.4, but I was wondering if that was maybe the Fib4, because the child's Pew is usually, child's Pew and MELD, I would calculate those on him. Those ones both, you need the INR to calculate, but those give us more information about his kind of long-term prognosis in terms of his liver disease.
Maybe I did have those turned around. I'm sorry.
That's okay, Sue. No, I think that is a Fib4, but even still, that one, you know, that wouldn't really give us 2.49 if that's his Fib4. Anything over 3.25, I believe, is kind of the cutoff for advanced disease. And those are kind of, remember, just kind of quick calculations that we can do. But that one, with that value, it really wouldn't give us any information. So it's not ruling out or rolling in, but your APRI is certainly high enough. And I do feel like he's got more advanced disease. But I would go ahead and try to get an alpha theta protein on him. you know, if it's elevated, you may want to grab an MRI of his liver rather than just the elastography. But the elastography, he's not overweight, he's not obese or anything like that. His BMI looked normal, so you should be able to get a good picture of his liver based off of that. But I would certainly get imaging on him. And then as far as treatment options, you know, with genotype 3, our two options are either Epclusa times 12 weeks. With him, he's treatment naive, so Mavorite times 12 weeks is also, or I'm sorry, times 8 weeks is also the other option. But I would really caution to use a protease inhibitor like in Mavorite without a real clear definition of how severe his liver disease is and how well compensated he is. So I would probably just go with the Epclusa times 12 weeks in this patient. He does have some drug interactions, and I'll let Rachel talk more specifically about those, but I think we could work around those with some dose reductions or some adjustments. But I know sometimes the access to medications and labs with health rates, it's kind of hard to get more than what you're given.
Would it be
Go ahead.
wise for, yeah, would it be wise for me to just encourage him to come to you, or just let you make sure that I'm doing all the right things for him through health right?
Oh, Sue, I have full confidence in you, girlie. I know you'll do fine. He doesn't need to see us. I think, you know, if after he's treated, he's somebody that, again, I would make sure you're really getting a good liver fibrosis assessment. But to be honest, I guarantee his fibrosis calculations are going to say he's going to be either F3 or F4. If his liver enzymes still stay elevated after treatment, then I would consider referring him to hepatology for further evaluation to see if he has any other additional chronic liver disease conditions that just maybe weren't diagnosed. But if his liver enzymes are normal, if his liver disease is stable or compensated, he's not jaundiced or has ascites or is getting like lots of leg swelling or encephalopathic, you know, I think that you can confidently treat him and then follow him thereafter. And then the billy in his urine is probably from either Hep C or that inflammation, that hepatitis, and or that liver component, the cirrhosis. So you might, even if you repeated a UA, you might still see that in there, but there's not anything to necessarily do about that. The blood in his urine is a little more concerning to me though, than the billy, just because he's got, you know, it could be nothing. I would go ahead and just repeat a urine on him to see if there's still blood in his urine. But if he's had some of that, it said on the report, like some suprapubic tenderness, you might want to just get a bladder scan, because there are some risk factors for, you know, for like a renal cancer. He's over 35, he smokes. You know, it could be like a urinary infection. It could be, you know, a renal issue. But I think that, you know, if just repeating it first, and if there's still blood in his urine with the second repeat, then we can kind of talk about further steps and either a referral to nephrology or urology and like a CT of his abdomen and pelvis. But I just would repeat it first.
Okay. Thank you so much. I appreciate that input, and I feel like I know what to do with him a little bit better, a little more confidently. You spoke all the things I was already thinking, so thank you.
Wonderful. That's great. That's a good thing. That's great. I love hearing that. And I have to commend you. I mean, really, it's really something, because when you're reading about a patient and just that case report, and we're looking at everything objectively, but then when you're talking about him and, you know, you say how motivated he is and how he's had this, you know, his sister that was a real player in his sobriety, and then, you know, devastating things that happened with her. I mean, that just really adds to it, because that brings back that humanization of our cases. And so thank you so much for presenting him, because you really did an excellent job.
Thank you.
And this is Rachel. I'll just go ahead and tag in here from a drug interaction standpoint and some issues. Like Kaylee said, you know, we do have that concern with the Mavorite, with the protease inhibitor, and probably more problematic with his atorvastatin. Those pesky statins always causing problems from a drug interaction standpoint with our HCV meds. So it's contraindicated with Mavyret. And then with Epclusa, it's just recommended to monitor. So there's no specific dose adjustments or anything with that. So from the atorvastatin option or standpoint, the Epclusa would be a better option. And then we run into the pesky problem of the PPIs. So it looks like he's taken the pantoprazole. So remember, with the Epclusa, they didn't study it with any of the other PPIs. So their recommendation is the omeprazole 20 milligrams to change that to, and that he would have to do the specific administration with the omeprazole. So he'd have to do the Epclusa with food, and then 4 hours later take the omeprazole, that 20 milligrams once daily. And outside of that too, double check me, Kaylee, because this is one thing that I always get nervous about with genotype 3s and the potential, if he is cirrhotic, I think he's going to need that resistance testing for that Y93 mutation just to see if additional medication might need to be added. Is that correct, Kaylee?
Yes, absolutely. I'm so glad that you said that, Rachel, because I did not mention that, and that's super important. So genotype 3 with cirrhotics, and like I said, we don't have a clear-cut picture that he's cirrhotic, but I would err on the side of he likely is, if not has already advanced fibrosis. But with genotype 3 and cirrhosis, there are actually, there's a huge significantly reduced sustained virologic response if they have that Y93H mutation. So that's when you would have to do the NS5A baseline resistance testing, the polymorphism testing. And Sue, I can help you order that. It's a really weird test to order. Like, even if he's having his labs drawn at Ruby, we have to put it in as a help lab. So I can help you with that. I'll send you an email or something with how to order that. But you know, the rates of clearance of sustained virologic response, if they've got that mutation and are genotype 3 and have cirrhosis, it's around like 30%. So it really reduces. And so if that's the case, then you know, we'd either have to use another option or add ribavirin, or in some cases, you know, extend the course, but typically add riba. So it is a little bit more complex because he's genotype 3. But again, that's going to be if you have, if he is cirrhotic. So if either of the fibro test or the elastography is consistent with F4.
Thank you. And thank you so much, Rachel, for bringing that up. It had completely fallen off my brain, and I knew I needed to ask about that. So thank you.
Thank you so much, everyone. That was a great presentation. No worries about the connection. That's just part of the game. We're doing Zoom these days, so I think we're all kind of used to that. I really appreciate everybody's comments to the case. And now, are you ready to move forward if there's no further comments or questions?
I'm good.
Right.
Thank you so much.
Thank you. I'll take that as a yes. All right, Dr. Gilfus, I've given you capability to be a co-host, so whenever you're ready, you can go ahead and start.
Okay, am I unmuted? All right.
You're good.
Yeah, thumbs up. Great, great case, by the way, Sue, and super advice from Kaylee and Rachel. Definitely a complicated one. One of the rare possible cirrhotic genotype 3s that we see. So I'm going to talk to you guys today about actually a fun topic, extrahepatic manifestations from Hep C. And I'm going to start off with just a comparison. So remember that hepatitis C has some notorious company that are also flaviviruses. Yellow fever, West Nile, dengue, dread Zika. So the reason I bring those up is, you know, those are feared viruses. with a lot of systemic manifestations, including hemorrhagic fevers and septic shock and death and systemic stuff. So, we use the word hepatitis C, and it can lull us into this sense of security that we're dealing with just a liver disease. But I would like it if its name was mostly hepatitis C. That would be cooler. We should start that. We should make that change. Mostly hepatitis C. Because it's a systemic virus, as we evidence. We look at liver enzymes, but we also look at viremia. Every drop of blood, there's a lot of antigen, and it's going to be a lot of downstream consequences. These are not extrahepatic manifestations of hepatitis C. So the clinical symptoms that we attribute to hep C are just that. They're symptoms, and they're not. They would meet not what we would consider extrahepatic manifestations. These are, these are some of the coolest ones because they've taught me so much about the practice of medicine in the past 15 years to go from telling patients that we know best and that you don't have any symptoms attributable to hep C to accepting patients at their subjective and listening to them and believing them that their fatigue and pains and aches and not feeling well and not thinking well genuinely is real and not just part of being a tired American has been one of the blessings that direct-acting antivirals have given to me, not just in hepatitis C care, but across patient care in general, and made me listen to people more and trust them as being the true, genuine expert in their own experience of life. And so it really took Harvoni and Epclusa and Mavorite to come forward and let us cure hep C before we understood how prevalent actual symptoms are. So, but that's not what we're talking about today. That's the symptoms. What we're going to talk about is extrahepatic, genuine manifestations, so disease processes in other organs. They're probably pretty common. Their prevalence really depends on how good we stop and take a history and how much blood work we do. So how much we search for them. And a lot of times I honestly don't search really hard because I'm going to treat the patient and they're going to go on. And that's the punchline of kind of all of this stuff, of all the extrahepatic stuff, is you treat it by treating the hep C in general, with a couple exceptions. But there's none of them that you don't want to treat the hep C for. So treat the hep C and see what's left. But the harder we look, the more we'll find. What's the mechanism? The first one here, direct viral tissue damage. This speaks to the fact that, again, this is mostly hep C, not only hepatitis. So you can have other target tissues, including the pancreas. That's where diabetes is going to come in. So then there's this inflammatory response, an immune response. We know that our immune system is a wonderful thing, but our immune system is a double-edged sword. And as it's trying to kill one thing, it can cause it's less than precise on occasion and can have some bystander side effects. And that's sort of the chronic inflammation that comes from fighting an infection that it can't cure. So chronic immune activation and that inflammatory milieu, which is bad for cardiovascular disease and bad for all sorts of whatnot. And then remember, the immune system is so frustrated that it has an incurable virus. It starts doing whatever it can do and starts making antibodies. And a lot of those antibodies are directed towards nothing, but some of them are directed towards, unfortunately, epitopes in our own cells or in our body. So we can get some autoimmunity. This is the next slide, the next part says many of them are managed by treating hepatitis C. And then the last thing in all bolds is really important. It says may not correlate with degree of hepatic fibrosis. So, the centrality of most of what we do when we're talking about these cases is focus on the liver and the liver's health. And we look at the transaminases and we do the fibrosis assessments. But remember, even if you had somebody with normal liver enzymes and F0, they can still have extrahepatic manifestations, including serious ones. Now, That being said, it tends to correlate with time. So a lot of these are time dependent, require a bit of years or more before the immune system revs up and causes the trouble that we're worried about. So this is just a slide. We're going to go through each one of these individually, so I'm not going to read it to you, but there's a lot of systems involved. The next slide is actually nicer because it has all those systems, and then it has blow-ups underneath of the particular names. So if we look at the blood, cryoglobulinemia, some ITP, lymphoma, that's a terrifying one. A lot of skin stuff, including porphyriocutaneous tardive lichen planus, vasculitis, kidneys, the pancreas and the thyroid, dry eyes, corneal involvement, and even retinal involvement or uveal inflammation, vasculitis, brain abnormalities, peripheral nervous system abnormalities, joint abnormalities, etc. So tons and tons of stuff outside of the liver, and we're going to go through those. Starting off with the endocrine system. The next slide talks more about diabetes and insulin resistance. In this slide, I'll primarily focus on the thyroid. We probably should, in our patients on initial intake, check TSHs on patients who have hepatitis C. You can have functional or anomalous autoantibodies. So you can have Graves' disease, you can have Hashimoto's, so both hyper or hypothyroid. Just a little interesting aside, I don't think Dr. Feinberg's on, but she's probably the only other person on here who's treated hepatitis C with interferon. One of the crazy things with interferon is we would actually sometimes induce increased autoantibody production. Remember that interferon is a weird drug and stimulates the immune system. And so we would see hyper and hypothyroidism fairly commonly during interferon therapy, which, boy, that was confusing because, you know, you had somebody who felt tired and we were giving them a drug that makes you feel tired. So it was a hard one to sift through. But just think of the thyroid. That's what all this slide says. Think of the thyroid, check TSHs on baseline, at least on our initial intake. Sugar and insulin resistance and genuine diabetes. So insulin resistance fairly common, genuine type 2 diabetes as well, and then that metabolic syndrome. Mechanistically, it's interesting. So the virus tends to have this direct effect on destruction of pancreatic islet cells, and then therefore development of diabetes, number one. And then there can be the opposite, where that's hepatitis' sort of causality on diabetes, and then insulin resistance, increased hyperglycemia, genuine diabetes actually can accelerate fibrosis, can accelerate sort of the milieu that lays down fatty liver, etc. So it's these two things feed negatively onto each other, unfortunately. Dry eyes and salivary glands swelling, so Sicca syndromes, dry eyes, dry mouth, isn't something that I routinely ask people about, but I probably should. After preparing this talk, it's actually fairly common. And so if you do have a patient with a sort of a Sjogren's or a Sicca type presentation with dry eyes and dry mouth, maybe this is something we can improve with treating their hepatitis C, which is always great. So the kidney is another organ that is sort of a bystander in this. It's not directly infected by the hepatitis C virus, but it is a filtering organ. And as such, the immune complexes, and again, I have a kind of a picture that shows what that looks like, but it's, you know, the antibodies cross-linked with virus, cross-linked with more antibodies, can deposit out in small to medium-sized vessels, and those include the glomerulus, unfortunately. And after they deposit out again, they activate complement and cause an inflammation and destruction, i.e. a glomerulonephritis, and with all the sequelae of a glomerulonephritis, including elevated creatinine and proteinuria and hematuria. So this is something you'd suspect in patients who have an abnormal urinalysis, have elevated creatinine, and so on and so forth. So certainly worth doing a UA on our patients while we're seeing them for hepatitis C. Again, we're looking for protein, blood, And again, we always check creatinines as part of our basic metabolic workup. So I have seen this infrequently. It's usually diagnosed by a nephrologist via a biopsy. But it can be suspected by us non-nephrologists based upon our non-invasive testing, as mentioned. And again, it was definitely an extra motivator to treat people. So get them treated, decrease that immune complex deposition, and hopefully, fingers crossed, see improvement in creatinine, etc. Okay, so sort of moving away from the kidney then to the blood. A lot of different hematologic and then lymphoid tissue disorders, and these are some of the more serious ones as well. The first one being ITP, and the ITP is a real challenge in people with hepatitis C, because remember, and no, I should clarify that, it's a real challenge in patients that have concomitant cirrhosis. So remember that the CBC of a cirrhotic patient tends to be have cytopenias, in particular lymphopenia and thrombocytopenia. So if you do have a patient who has known cirrhosis and has low platelet counts, they probably don't have ITP. They probably just have the sequelae of cirrhosis. But if you have a patient who, you're kind of shocked how low their platelets are for what otherwise would be a healthy liver, remember that you can have antiplatelet antibodies, i.e. ITP. This presence of ITP is also one of the reasons we don't like to rely simply upon APRI or FIB4 for diagnosing advanced liver disease or cirrhosis, because you could have somebody whose liver is fine, but if they have ITP and platelets are really low, the APRI or FIB4 is going to give you a falsely pessimistic answer. So again, another shout out for why we want to use multiple modalities for fibrosis assessment, like elastography or FibroShort. Okay, so that's ITP. Mixed cryoglobulinemia, a big word. We're talking about that in a second. MGUS, monoclonal gammopathy. And I have a question on that one because that's probably the least well associated and often actually is part of cryoglobulinemia. So I'm not going to talk about that much, but we'll talk about cryoglobulinemia and definitely lymphoma. Those ones are scary and important not to miss. So cryoglobulinemia, again, this is sort of the sequelae of immune complex deposition and immune system activation in the wrong spot. And it tends to precipitate in a couple different target tissues that we clinically detect. It's probably all over the place, but the target tissues that we tend to pick it up on is skin. So we'll see this present as palpable purpura, i.e. vasculitis, or as a patient like to say, I have a rash. And that rash tends to be, can be anywhere, but usually lower extremities. If you see it acutely, it looks like purple spots. If you see it after it's sort of gone through its healing stage, it can look like little brown hyperpigmented patches and even ulcers if you have any skin necrosis from it. So basically rashes, number one. Number two, joint pains. And then number three, I already talked about immune complex deposition causing kidney trouble, so it could present with an abnormal urinalysis. So sort of the trifecta of cryoglobulinemia would be, I don't feel good, I ache all over, my joints hurt, I have a skin rash, and my UA looks abnormal with protein or blood. And we can see cryoglobulinemia in a lot of people, but most of them don't have symptoms, okay? And we wanna treat people for their hep C and hopefully improve their cryoglobulinemia for reasons that I'll explain in a second. So this would be sort of an active palpable purpura. This is an active vasculitis. If you touch these, then you might be able to feel them. They're not blanchable. This is a really robust example. A lot of times it's only a little patch here or there. And again, they may look less purple with time and still worry. So sort of the spectrum of cryoglobulinemia, it can be sort of something you detect just on labs, or people can again have this vasculitic rash, joint pains, and tiredness, and at which point it probably doesn't require any directed therapy other than treating the hep C, but it can take on a life of its own, especially if it starts causing end organ damage to the kidney, if you start getting immune complex deposition into nerve tissue and start causing mononeuritis multiplex or other stuff like that, you might have to actually shut down those antibody production more rapidly, which you could do with anti-inflammatories or even anti-B cell therapies like Rituxan, and so on and so forth. But just know that this is a spectrum of disease with immune system activation, production of immune complexes, deposition in various target tissues, and then eventually what you can actually see is that ongoing stimulation can progress in ways we don't exactly understand into sort of an autoproliferation, i.e. cancer, i.e. lymphoma. And that's one of the scariest things that can happen. One of the other cancers associated with hepatitis C. So everybody knows that liver cancer can come from hepatitis C, having to go through through cirrhotic formation first, but you can actually have a second cancer associated with hep C being lymphoma from chronic immune system activation. It tends to be B cells. So everything I've been saying today is talking about antibody production, aberrant antibody production, immune complex deposition. Remember, the cells that produce antibodies are your B cells. So this does tend to be a B cell stimulation and eventual B cell conversion into autoproliferation. So it's a B cell lymphoma. Here's a graphic that I like, because if you look at the top part, this talks about, there's the root cause analysis. There's HCV virion, there's our antibody being produced, and here's our cross-linked antibodies with a numerous antibody antigen complexes that deposit, activate our complement, cause local tissue damage. So it says end organ damage. That's to the skin, that's to the nerves, that's to the joints, that's to the kidneys. But at the bottom, it also talks about sort of what's happening to the poor immune system along the way. So this B cell repertoire is just endlessly flogged, being asked to do an impossible task, cure an infection that it can't cure. And eventually there's enough mutations and proliferation that occurs that some reason it just takes on a life of its own and becomes a lymphoma. Okay, skipping over to the next one, again, arthritis. And again, hopefully, as I'm going, you're seeing there's a great deal of overlap between the complex of immune system activation and autoantibody formation and immune complex deposition and all of these disease processes. So a lot of them have sort of the same root cause pathophysiology. And again, this arthritis can definitely be a consequence of autoimmunity, that's autoantibody production, or cryoglobulin, i.e., immune complex deposition, etc. So, but how would it clinically present? How does the hepatitis C arthritis present? It tends to present as an inflammatory process of the small joints. So stiff hands, hands that are having some pain doing simple tasks of daily living, like squeezing a tube of toothpaste, tying your shoes, opening door knobs, etc. That shouldn't hurt, otherwise start hurting. Very rarely this can be large joints, but it tends to be the small joints of hands and feet. Remember, one of the cruel tricks of nature, this will look like an inflammatory arthritis and have a positive rheumatoid factor almost all the time. Remember, rheumatoid factor is what? It's an antibody. It's an autoantibody directed towards the FC component of other antibodies. So remember, the whole issue here is the immune system is stimulated to produce aberrant antibodies. So almost all of these patients are going to have positive rheumatoid factor. Don't fall prey to thinking that's rheumatoid arthritis. So remember, if you have a patient with a history of rheumatoid factor positivity, make sure you've looked for hepatitis C, hepatitis B, HIV, and then do confirmatory rheumatoid factor testing like CCP antibodies. We have seen patients who are falsely labeled rheumatoid arthritis, who just in fact have something along the spectrum of hep C induced arthritis. We also have seen people who have genuine rheumatoid arthritis and hep C. So you can't have them both. But most of the time it's just, this is hep C acting badly. And the management difference is huge, immunosuppression versus antivirals. And so it really matters to that extra test. Our rheumatologists are wonderful about checking that, but remember to do that in patients that you do consider labeling as rheumatoid arthritis patients. Make sure you've checked your hepatitis serologies and HIV serologies. all of our patients that we do see in clinic, so I already mentioned we should probably do TSHs on everybody. We should do urinalyses on everybody on day one, and we should probably do rheumatoid factors. So this algorithm right here advocates that we screen for this common cryoglobulin problem. Remember, this is relatively common in our patients with Hep C. How do we screen for it? You can send cryocrit, but they're cryoglobulin testing, but it's hard. There's a lot of technical difficulties. So the author of this paper suggested we start our screening by doing rheumatoid factor. And if that's positive, which most of the time, if you do have a functional cryoglobulinemia or other extrahepatic manifestations that are a consequence of autoantibody production, a lot of times rheumatoid factor will be positive. Again, remember, rheumatoid factor is just an antibody directed towards other antibodies. And if that's positive, that is sort of our entrance into additional testing, at which point we would order our specific serum cryoglobulins, check our complement levels, which are universally low in the setting of immune complex diseases. Make sure there's no monoclonal gammopathy, make sure there's no kidney involvement, test for some of our other triggers of positive rheumatoid factor, that's HIV and HBV. Not on here, but you could do a CCP test as well. So rheumatoid factor should probably be on one of our core tests that we offer on intake for patients with Hep C. Nerve involvement, the nervous system, or I'm sorry, the nerve involvement from hepatitis C tends to be a mononeuritis. So it does not tend to be peripheral neuropathy like you see as diabetes. So generalized bilateral symmetric distal neuropathy is not what you expect to see. You tend to see a mononeuritis, so actually like a particular nerve distribution numbness. And again, this is an ischemic insult from immune complex deposition in the vasa vasorum, so the blood vessels that actually supply the nerve infarct, and therefore you can get a mononeuritis. I have seen this, but it's very uncommon. And we already talked about sort of just aches and pains and not doing well. And that can be either coming from the Hep C itself, or it can be a sign of cryoglobulinemia. How do we differentiate it? Through this stuff, rheumatoid factor, and then look for elevated serum cryoglobulins and low complement. Skin stuff. So we've already talked about the vasculitic component that can come along with hepatitis C via cryoglobulin production and deposition in the small vessels of the skin, which can present as a vasculitis. You can also itch a lot with hepatitis C. I don't tend to see that a lot outside of people who have elevated bilirubins. You can get lichen planus. I have seen this in various body parts with Hep C. You can get a couple of the scary erythemas, E. multiforme, enodosum. I've never seen either of those. Remember, E. multiforme is that targetoid looking lesions all over the place. Enodosum is that paniculitis on the shins. I've never seen either of those. Idiopathic urticaria. I do keep that in the back of my mind for people who periodically have hives of unclear etiology. I include usually HIV, hepatitis, and syphilis testing for people with idiopathic urticaria. Porphyria cutaneous tarda, I'll show you a picture of what that looks like in a second. So here's a picture of lichen planus in the skin. Again, can be attributed to hepatitis C. Not always, it can be idiopathic, but Hep C can't cause it. Porphyria cutaneous tarda, again, mechanistically you have an enzyme in the liver that normally would be involved in bilirubin breakdown, heme breakdown, and so therefore get elevated levels of some uroporphinogen or some word I just made up in the blood that then deposits in various target tissues. Fortunately for porphyria cutaneous tarda, it's not one of the porphyrias that causes neurologic or abdominal issues. It tends to be cutaneous. What you will see as a clinician is scars on the hand from prior episodes of what become little hemorrhagic blisters. Those hemorrhagic blisters tend to occur in the setting of sun exposure or small traumas. So the questions you would ask your patient is, hey, do you tend to get a lot of little blisters or that turn into scabs and scars in sun exposed areas, or if you get a minor trauma, does it tend to develop into a little blister easily, and if so, that could be porphyria cutaneous tarda, and a sign that they're dealing with an extrahepatic dermatologic manifestation of mostly Hep C, and palpable purpura from vasculitis. And I actually like this one because it shows some of the older vasculitic lesions that kind of can turn brown over here. So, and again, mechanistically here, this is immune system activation, immune complex deposition, and on the spectrum of cryoglobulinemia most of the time. So in conclusion, while the darn virus is named hepatitis C, we're going to all recollect that as while it's hepatotropic, it does have other target tissues that we should, as clinicians, take good histories and listen to our patients, and definitely do a good review of systems, and do labs not just involved in the liver, but do TSHs, urinalyses, and rheumatoid factors, etc., to make sure we don't miss any of these extrahepatic manifestations, and counsel your patients that a lot of these will get better. A lot of them will get better, but they do require patience. So again, immune system does not turn off. After you treat the virus, the stimulation of the immune system will slowly decline with time, and therefore improvement may be slower than actually their expectations. So I try to tell them, let's be patient with your joint pains. Let's be patient with your skin rash, et cetera, and then eventually you should have improvement with time. If not, revisit the diagnosis. All right, I'd be happy to take any questions on mostly Hep C, extrahepatic manifestations.
Thank you so much, Dr. Gilfus. That was a wonderful presentation and reminder to be, understanding how complex this is, and to really talk to your patients about the patients that it might require to see the results they need. I'm sure that would be difficult to hear for anyone, but it's a nice reminder for them. Does anybody have any questions or comments they would like to make? I did see in the chat, Susan really thanked everybody for their input and support. More than she can say. That's really sweet of her. And then Jennifer Boyd said a great didactic. Thank you so much.
I'm just curious whether anybody is thinking they'll go any other direction. I just was scribbling down a name because I saw somebody this week with kind of an unexplained high rheumatoid factor. Is this somebody I should be getting Hep C testing on? I mean,
Yeah,
it's an elderly lady, but who knows?
No, that's great. I 100% would. That one slide that said if you got an elevated rheumatoid factor, you should probably check Hep C, Hep B, HIV, and go from there. And I don't have it on this didactic, and I should, but low titer ANAs are real common on patients with hepatitis C. So, a lot of times we get ANAs on people who are hurt. They just we don't know what they got. They just don't feel good. So we end up at some point screaming for lupus, and we see low positive ANA. But that should be definitely another group that gets screened for hepatitis C. I don't know why I don't have it on this talk, but as one of those autoantibodies that's actually quite common in Hep C patients is ANA.
Yeah, so it just gives me more things to check for.
Even more reason to screen for Hep C. Right on.
Just screen everything, just please. I need a full body scan. Everyone.
Paranoia is what I seek to spread. Exactly.
No, thank you so much. That was a great question, Carmen. Thank you very much for that question and insight from Dr. Gilfus. Anybody else? Haley said, great job, super informational. Don't want to take off mute because there's construction going on at my house and it's noisy. Thank you, Kaylee. No worries. Really appreciate the kind words. Any other comments before our final announcement of the session? All right.
Let us know what the resistance testing on that genotype 3 comes back.
Will do, definitely. Thank you so much.
Thank you. Yes, a follow-up, or if you want to do a follow-up case with that, that'd be great, just to see how that individual's doing. That's always encouraged as well, especially with any complex cases. So my only announcement is our next session will take place on August 12th, and we'll be having a special guest speaker. and it's Dr. William Cook. And he was the only physician who was working in Scott County, Indiana in 2015 when they were experiencing their HIV outbreak. He has a book he wrote about that experience. So he will be doing the didactic that day, and more to come on the exact topic whenever I receive it from him. So we look forward to seeing everybody then, and please have a beautiful weekend. Thank you so much for joining.
Thank you, everyone.